This budget hearing conducted by the Committee on Appropriation and Adjudication will now reconvene with the Guam Behavioral Health and Wellness Center. I want to thank Senator Castro for joining me this afternoon. Mr. Vega, thank you for bringing your management team with you. Why don't you go ahead and proceed with presenting your budget.
Thank you, the Honorable Speaker and Chairman of the Committee on Appropriation and Adjudication, for giving us the time and opportunity to present our budget proposal. Our Guam Behavioral Health team is composed of myself as Director, Mr. Benny Pinaula, the Deputy Director, and to my immediate left, Reina Sanchez, Clinical Administrator Acting, and immediate left is Annie Umpinko, Administrator for Child, Adolescent, and Service Division. To my extreme right is Maylie Sampson. She is the HR person, and to her left is Debbie Paulino, Administrative Officer. Today we will start with a presentation, a PowerPoint presentation, as far as the operations of the department, and it will be done by the Deputy Director, Benny Pinaula. Good afternoon, Senators, Senator Mary Torres, my oversight chair, Senator Dennis Rodriguez, and Senator Will Castro.
Good afternoon. Thank you for, again, allowing us to come before you and present our budget. So we're going to start off with our presentation with our PowerPoint. Next slide. Next slide. Our mission statement: to provide a culturally respectful, quality behavioral health service that supports and strengthens the well-being of the person served, their families, and the community in a safe environment. Next slide. Our vision statement: we envision a healthy island committed to promoting and improving the behavioral health and well-being of our community. These two mission statements and vision statement is what's driving us and what is moving us forward in our budget. As you can see on the PowerPoint slide, this is the fiscal year 19 ceiling level option 1 at $15,471,552. Of that, 12% is coming out of the general fund and about 88% out of the Healthy Future Fund. Next slide is the appropriation for FY18 at $20,830,291. Next slide. Our fiscal year 17 total appropriation was at $22,448,469. Next slide. And our FY16 total appropriation was at $22,329,459. Next slide. We've broken it down by the various divisions and the Director's Office, which provides the overall administration and support service to all divisions, sections, and programs to assure quality service to the consumers and the community. The office manages all funds and the resources sponsored for all divisions, sections, and programs, and strategically aligns administrative units and functions directly or indirectly impacting patient and consumer care. Throughout the program development, quality management, policies and procedures, fee schedule development and implementation, information management, fiscal service, human resource, training, regulatory compliance, facilities and plant operation, and professional services. The number of existing employees under the Director's Office is 119. Again, general fund is $1,301,307. Healthy Future Funds, $8,782,757. And to cover the existing employees, $8,743,964. Total of $10,084,964. Next slide. The breakdown for that, as you can see, is the Director's Office has 19, and under the FMT created position, we have 100 positions. The budget by department, Director's Office is at $3,098,095. The FMT created positions at $5,645,869. Next slide. The Clinical Service Division. Community Support Service, the Medical Records, the Residential Recovery Program, Prevention and Training, Adult Counseling, Drug and Alcohol, Patient Affairs, Contract Management, Pharmacy. Supports the organization's mission to provide the highest standard of care and strengthen our island's community by enhancing every person's emotional and behavioral health through evidence-based practices that is person-centered and culturally responsible. The number of existing employees in the Clinical Service Division is 28. The general fund covers $346,686. The Healthy Future Fund covers $1,523,251. To cover the existing employees, we're looking at $1,523,251, total of $1,869,938. Next slide. The breakdown for the clinical division. For staffing, we're looking at community service support at 10, medical records 1, residential recovery program 14, prevention and training 1, adult counseling 1, drug and alcohol 1, and we have federally funded 9 positions under that department. The budget by department, CSS receives $588,611, Med Record $69,806, RRP $659,521, Prevention and Training $67,508, Adult Counseling $90,406, Drug and Alcohol $47,399. The federal funding match $555,798. Next slide. A little bit of the breakdown for the RRP, the Residential Recovery Program. Next slide. These are the adults between the age of 18 and 80 years of age. They have severe and chronic mental illness and willing to develop skills for independent living. Next slide. On level 3, there are 3 levels, and level 1 is the highly structured environment with extensive regular personal care, constant close supervision, and significant severe behavioral concerns. Next slide. Level 2 is moderately structured environment, limited personal care, regular supervision, minimal to moderate behavioral concerns. Next slide. The third level is a less structured level environment, minimal to no assistance in personal care, regular to minimal supervision, minimal to no behavioral concerns. Next slide. The Aging and Medical Needs Home, Guma Asasena. This is our individuals who are 60 years and older. They are in need of medical supervision, neurological, cognitive, and organic brain disorders. They have registered nurse visits regularly to monitor their medications. Next slide. And then we have our day treatment service. The goal is to enable the consumer to learn skills needed to live, learn, and work in the community with the least amount of assistance. Groups, medication and symptoms management, social skills, cooking classes, stress management, understanding emotional psychotherapy. Next slide. The Child Adolescent Service Division. To support and empower and strengthen the child and family ties by making these mental health services accessible to not only children and adolescents with severe and complex mental health needs and their families, but to all children and adolescents that may be at risk in the need of mental health services. To develop collaborative partnerships with families, agencies, community stakeholders to sustain a system of care for children, adolescents, and their families. We have a step-down, transitional home, serenity home, short-term intensive psychiatric stabilization, therapeutic group home, and Ifumagonta. Number of existing employees, 25. The general fund covers $167,671. Healthy Future Fund covers $1,491,144. To cover the existing employees, we're looking at $1,491,144, total of $1,651,815. Next slide. The breakdown for the Child Adolescent Services Division, we have Child Adolescent Services with 22 and IFA Magonta with 3. Budgeted by department, the Child Adolescent Services, $1,299,948. IFA Magonta, $191,196. Next slide. Nursing Services Division. Skilled nurses and psychiatric technicians provide crisis stabilization care to adults and children with acute mental health symptoms and those with chronic behavioral issues. Nurses oversee licensed practical nurses, psychiatric technicians of adult inpatient and children adolescent inpatient units. Medication clinic, psychiatric community outreach, nursing services, PCONs, 24-hour crisis hotline, the after-hours emergency intake. All nursing staff promotes quality health care, provide acute and chronic nursing service to individuals with mental illness, emotional stress, behavioral problems, and addictive behaviors. Nursing staff also works with our other disciplinary teams to provide holistic care for the consumer they serve, promote a safe and clean environment, strive for excellent quality of care, and enhance the operations to meet increasing demands and complexities in a timely manner. The inpatient, adult, and children's, medication clinic, and psychiatric community outreach nursing services. Number of existing employees, 25. General Fund, 0. Healthy Future Funds covers $1,865,735, and to cover the existing employees, $1,865,735. Next slide. Breakdown for Nursing Service Division. Nursing Services, 21. Healing Hearts Crisis Center, 4. The budget breakdown by department. Nursing Services, $1,583,443. Healing Hearts, $282,292.
Thank you, Mr. Pinala. So I will proceed and present my written testimony. The Honorable Speaker and Chairman of this Committee on Appropriations and Adjudication, Benjamin Cruz, the Honorable Senator Mary Torres, my oversight chair, Senator Dennis Rodriguez, and Senator Will Castro. Thank you for this opportunity to present the Guam Behavioral Health and Wellness Center proposed budget for fiscal year 2019. I would like to emphasize that it is a proposed budget because at the end of my testimony, I will, and in behalf of the staff and management of the Guam Behavioral Health and Wellness Center, the persons and the people we serve, we will be asking for your assistance to fund outsourced contractual services with serious consequences if not funded and addressed. For the most part of my 6 years on my administration at Guam Behavioral Health, we, and I mean most especially the staff and the frontline service providers, have made a lot of difference to the lives of our persons served and their family and community stakeholders that provide supports for our clients, the most vulnerable group. I am quite sure that we are all aware what's going on nationwide and around the world. Mental health issue and substance use and abuse disorder that knows no borders and boundaries. It can happen to the rich and the famous, the haves and the have-not. It does not discriminate anyone. Every day as we turn our TV sets or radios, we hear tragic events in all levels of society, with more or less the common denominator is mental illness and substance use disorder. In Guam, Guam Behavioral Health and Wellness Center is mandated to provide comprehensive mental illness and substance use treatment and services. The past 3 years have been a very exciting year for Guam Behavioral Health. Guam Behavioral Health has achieved a lot of accomplishment, and thanks to the staff who willingly sacrificed their own personal life, time, and to make this happen and to be part of the game-changing initiative at Guam Behavioral Health. Only to name a few, as I'm quite sure I will fail to mention most of them, the little miracles and successes that happen every day at Guam Behavioral Health. Guam Behavioral Health is a single state agency mandated to provide comprehensive mental health and substance use treatment and services. For the first time, Guam Behavioral Health was awarded the maximum 3-year accreditation from 2017 to 2020, the highest level of accreditation after a comprehensive accreditation survey conducted by 3 surveyors from the Commission of Accreditation and Rehabilitative Services. And CARF, a nationally recognized accrediting body. CARF recognizes and accredits facilities such as Guam Behavioral Health for meeting national standards in the delivery of service and treatment to our people. And every year thereafter, we have to meet new standards that are nationally recognized and incorporate them in our day-to-day operations in order to maintain its accreditation status. In short, Guam Behavioral Health is an accredited facility nationally recognized, a recognition and testament that we are providing quality care, treatment, and services with evidence-based practices and with fidelity. The programs accredited for the next 3 years are Healing Hearts Crisis Center, Crisis Intervention for Mental Health, both children and adult, Crisis Stabilization Inpatient Unit, Mental Health for both children and adult, Intensive Outpatient and Outpatient Treatment with a New Beginning Drug and Alcohol Program, Adult Outpatient Mental Health Program, Child Adolescent Services Division, Prevention and Training Branch, and Residential Treatment Health Recovery Program. This year we have new initiatives and programs that I think the community of Guam will benefit. We started work on the Mobile Response Stabilization Services. MRSS plan will be developed in 2 phases. Phase 1 is to improve the existing crisis line of Guam Behavioral Health and Wellness Center and to be referred to as Crisis Helpline. Location will be at the Rays of Hope building, possibly using a 211 or 311 line with gradual transition from the existing number of 647-8833-8834. The Phase 2 is the most exciting one, and this is the brainchild of Ms. Aniam Pinko, who heads the Child and Adolescent Service Division. This is the Phase 2 is the implementation of the mobile response team when the incoming call warrants a team of trained mental health professionals to respond out into the community. The primary team consists of psychiatric social workers, and community program aid. The existing Guam Behavioral Health trauma response team, who provides debriefing on traumatic and tragic events or during disaster, both natural and man-made, in the community may be tapped as an additional resources. Another exciting one is the fully assisted therapeutic group home for adults, a residential facility operated 24 hours, 7 days a week, 24/7 fully assisted living facility that provides home-like environment or atmosphere where individuals who have severe and persistent mental illness can reside while receiving therapeutic treatment. All residents are encouraged to engage in the operation of the household and take part of the responsibility of daily household chores with the close supervision of psychiatric technicians under the guidance and clinical team consisting of psychiatrists, psychologists, social workers, and counselors. The program uses both individual and group approaches in assisting each individuals to develop skills in symptoms management, as well as interpersonal and practical living skills within the structured residences. The staff assists the residents in establishing and maintaining connections with services in the general community. Symptom management is the primary focus of the program to help individuals stabilize and function well on a day-to-day basis. The good news to this, the first 2 projects are to be funded by Department of Interior grant money initially programmed for the residential home for the 4 long-term clients that are residing in off-island facility. We have requested a reprogramming because we have determined that the 4 clients that living in the residential facility, it's not in their best interest to come back. So instead, we plan a therapeutic group home for others who are there and can be brought back. And at the same time, this would eliminate sending clients who are in need of a fully assisted living facility. I can tell you right now that we have the capacity to do this. So the set-aside money of $1.2 million is already there. All we need to do is just do the renovation and everything. Because of this project, especially in the therapeutic group home, this would be a lot of saving of not using residential treatment fund to send clients off island. Currently, as presented earlier, Guam Behavioral Health runs 4 residential recovery program homes. These are transitional homes and 1 home for the aging. This would complement what we have right now. I'm referring to the therapeutic group home we're in. These are a group of individuals that cannot independently live by themselves. They have to be in a fully assisted living facility. The PowerPoint has outlined to you all levels of the residential recovery program, so I'm not going to repeat that again. Another initiative that is quite exciting to us is a Department of Interior Technical Assistance Grant for the Guam Crisis Lifeline. Guam, again, as a single state agency for behavioral and substance prevention and treatment of services, is committed to build an existing suicide prevention effort by transforming the Guam's existing crisis hotline, a confidential information and referral helpline into the effective Guam Crisis Lifeline, using evidence-based and protocols to address Guam's high rates of suicide. The hotline will be revamped, utilizing evidence-based practices and protocols endorsed by the National Suicide Prevention Lifeline and meets nationally accepted and recognized standards. Guam Crisis Hotline will establish culturally appropriate evidence-based suicide prevention, assessment, treatment, follow-up programs, and practices that are standardized throughout the healthcare system and establishing strong linkage between behavioral health and medical care system. Guam Crisis Lifeline project will impact on the high rates of suicide by providing 24/7 days a week suicide prevention and clinical intervention, which could significantly reduce the suicide among children, adolescents, and adults. As we all know, we are one of the highest in the nation. Another exciting initiative that we have started about 2 months ago is we opened the Drug and Alcohol Day Clinic, a medication-assisted treatment. This is a gap in our system and has not been provided for the past 10 years. What we intend to, I have there a long description of what is ASAM 11.3.7, but in short, this is a medically monitored 24/7, and this is what was called before the new beginning. With the new
Mr. Vega, did you provide us with a copy of that? That's
Yes, yes.
We sent copies to your
We sent copies to Your Honor. Okay. So the level 3.7 is a gap in our service. This is a medically monitored inpatient, including physician-directed and nursing care. This is what we always call the old new beginning. If everybody remembers the 3rd floor at the Guam Behavioral Health and Wellness Center during the Typhoon Pong Songwa, if I'm not mistaken, was wiped out. So since then, we don't have the 3.7 new beginning level of care. But recently, we were lucky, we were able to hire a forensic psychiatrist with an addiction medicine experience. So instead of going directly to open the new beginning, what we did was slowly, so we could establish the number of clients. We have a good handle of how many and what we need to do. We opened a day clinic for drugs. He can prescribe Schedule 3, 4, and 5 medicine. So we have, for now, we're running a once a week clinic with prescription. This is what we call medication-assisted treatment. And this is also a good plan for what is to come in the national landscape, opioid crisis. So we have not had experience of a spike in the opioid use yet, but we're anticipating that in the very near future, we would see some cases of opioid addiction here. To operate the new beginning, the expected budget is $1.5 million per year. It is not included in my proposed budget because of the financial crisis we have right now. But once we establish the need, the total number of clients that are eligible for this new beginning, we would probably come before you and ask for your assistance. We are very proud. Guam Behavioral Health has, since July of 2015, is on a digital format. We have electronic behavioral health record, known as the award, and has been deployed since 2015 and currently operational. Since this is a cloud-based system, we are able to access record as long as there's internet connection and there's secured line that is compliant with HIPAA standard. How we measure our delivery of services, we created what we call a performance improvement activities that tracks most of our activities. For example, I'm not going to go to most of this, but we are tracking no-show, we are tracking our success treatment rates, we are tracking on the admission and the inpatient. 8 years ago, the average length of stay of clients in the inpatient unit is between 8 to 12 days. Currently, our average length of stay per patient is between 5.5 and 6 days. So we have significantly reduced the admission at the inpatient. And also I want to mention that quite recently the community social services have a program wherein we have a team of community program aid, social workers who would go to the community and conduct their community home-based services. So they're the one that monitors the progress of those clients who live in the community. They're visited every day. Now, Your Honor, this is the most challenging and troubling time for Guam Behavioral Health. The ceiling on the budget for Guam Behavioral Health, which is at $115 million plus for option 1 and 15 million plus for option 2 will only fund the day-to-day operation costs, and I believe could be manageable despite its shortfall. Obviously, what is not listed in my proposed budget is quite troubling because these are all for outsourced services. These are outsourced contracted services from Catholic Social Services and Gumamami, which serves a total client of 96. This, if not funded, would expire or terminate September 30, 2018. These services are so critical to the most vulnerable group, and I just don't see any way out but to ask you to find the funding. I have a one-page attachment there that lists the services and the total number of the funding cost, which amounts to about 4.77 million. Also, please note that the social detox program in the amount of 1.5 is not even in the proposed Guam Behavioral Health post-budget. Historically, since my administration for about 6 years now, social detox for drug and alcohol has always been budgeted under the executive branch miscellaneous line items. And almost always after the budget has passed through the legislation and approved, it is almost always transferred to my budget without the money following. So for the past 4 years, from the beginning of the fiscal year, I'm always short by 1.5 million. But so far, we have managed because of some lapse fund, and we came out able to provide the services. But currently, my biggest concern is from 20 million, I'm going down to 15 million for the budget, and that the difference would account for the all contracted services for Catholic Social Services and Gumamami. I beg you, your senators, to help me continue this program. These are the most vulnerable group. They will be disenfranchised, they would be displaced. Not only them, but would completely affect the family and the community. So if I'm here to ask for your assistance, if you could find some funding for the outsourced services for Catholic Social Services and Gumamami. Thank you for your time. Dankulun at Sidious Masi.
This is the second department today that has come forward with a request that was substantially different from what was in the executive budget request that was submitted in January. The amount that you're asking for just for the for the 5 contracts is 33% of the budget that's presented at 15,000. That doesn't even include the other programs that you've included in your testimony that you wanted. You want to do finally, long before you got to behavioral health and wellness, I've been screaming at your predecessors and your predecessor agency about the fact that your former last name, S.A., substance abuse, was not St. Augustine, but it was substance abuse, S.A. We're finally getting to that. But it's not in the executive budget request. The 5 contracts is a 33% increase. We add in your substance abuse, opioid crises request. We're talking almost a 50% increase in your budget as submitted. How is it possible that the executive could have submitted a budget to us and said, option 1, 15.7, option 2, 15.2, and you're coming to me now and saying, at the very least, 21, but ideally 23. Am I hearing that correctly, or am I reading this wrong?
Yeah, that is correct, Mr. Speaker. When I asked for the 2019 budget, I have included all of this contracted services in my proposed budget to the executive branch. They gave us a ceiling of 15 million.
Did you explain to them the impact of canceling those 4 contracts and the multiple number of homeless people that be walking in Agana because of the fact that we don't have them in those homes?
Yes, I did, Your Honor.
And they still submitted a budget, the executive budget request in January, claiming a balanced budget at option 1 and a balanced budget at option 2 with certain things in it that didn't include these 5 contracts.
We have to work on the ceiling that was given to us, so the only way for me to present a viable, not even a viable budget, but a budget that would completely impact on the most vulnerable group, and the only thing that I could touch are the contracts. So in my explanation to them, can you please help me how to fund this? Well, of course, you have the Guam legislature. Maybe you could help me find some funding source.
I understand, but the executive is supposed to set the priority. And I thought, I purposely scheduled yesterday GFD and GPD because I thought those were #1 priorities. And today I had DOC and you, and tomorrow I'm having the hospital because I thought those were the 5 most important. Last Friday I had education because I thought those were the top priorities. And now I'm finding out from you that the executive budget request submitted for this, what should have been a 100 agency, a top priority one, was shorted 33%. When your actual request was cut by 50%.
And that's what happened, Mr. Speaker. I asked for a...
And where is this revenue supposed to come from? We should have known this since the beginning, that this top priority agency should, straight off the top, should have been provided 23. I mean, I've been asking for years. I think Ms. Mpinko's been the only one that's been there since I've been here. And she's had to suffer me jumping every one of your predecessors about the fact that New Beginnings is not sufficient, that an in-house detox was imperative for what your department was established for almost 40 years ago. And now you're saying, yes, I wish I had this in-house detox for an additional 1.5, and I'd like to have those contracts back for 5, plus other programs? I'll have your oversight chair ask a few questions, and let me try to compose myself.
Thank you very much, Mr. Speaker. Thank you very much all for being here. I'm kind of in the same boat here with the Speaker because I know what we need to do. We've been talking about the New Beginnings inpatient service for every budget. We talk about it. For a long time, it was the personnel, right? You didn't have the specialists. Now you do have the specialists on board, right? Which is addiction specialists. But it's not part of the budget, right? So that's where my concern is. And I know one thing that's very important is the MRSS, the program that you want to stand up. And so, I'm going to we'll work with the Speaker, work with the committee, but it's difficult when you come in for a budget request with that amount, saying this is what you're given, but really, this is all that we need. We need more, we need to fund the contracts, and we need to fund the services. And so it makes it very difficult, but we understand what needs to be done, right? So we got to work together and figure this out and how we could fund these programs. But it is, I understand, again, the Speaker's position where to come here and say, this is what the executive branch's budget is, but this is the things we need. It doesn't hold well, but we'll, just like I said, we'll work and see how we can make it happen, because these are priorities. Especially now with the substance abuse problem we have, and now that you do have the specialists to stand this program up, it's imperative that we do everything we can to fund this program. So that's my position on that. The other, I do have a question on your lapses. I know in previous budgets you've done a good job in having lapses, right? What is your lapses now?
I don't have that right now, but I can tell you that the last 2 years, our lapses runs between 1.5 and 2 million. And that's part of that is the procurement delays and recruitment efforts. So
those are obligated.
Right. So for this year, I don't think I have enough lapse because we have the residential treatment program that we tried to support, because the appropriation of 1.6 is not enough to cover for both off-island and on-island services.
Okay. Just going back to the New Beginnings 3.7, that's the inpatient, the inpatient treatment service. Have you explored, perhaps getting a nonprofit, a third party to run that program?
We have talked with the current contracted service providers. None of them has the ability to provide clinical supervision. They don't have a nurse in their organization. Same thing with an addiction medicine. So that it's a must that there would be a physician. The 3.7 is a physician-directed, medically monitored treatment with an addiction specialist who would be able to prescribe some medicines.
So what about, and I don't know if this is done, but something to think about, what if it was done like some sort of public-private? a partnership, with the nonprofit, because you do have the specialists, you do have the nursing capabilities, the resources. Have you looked at that, and would that perhaps lessen the investment that's required?
That is something that we are currently taking a look at right now. There could be a possibility, but of course, the procurement process, what it will allow us to do and what we can't do. It's a different slope when you work with that kind of program, private partnership with the government. But we are looking at it. We've had some discussions. I've been to conferences, and some states are doing it. And if we can get the exact model template, we might be able to do it here.
Yeah, because I think that's probably one of the biggest problems is that as a government, we've always thought that we got to do it, right? It's got to be the government to do it. But I think if we really try to expand and work with the nonprofits, we'll really be able to get a lot from it.
It's also the procurement process too, right?
Okay, so procurement, and then you said there may be other problems. Tell us, what are those things that we're able to do? Because if we could change it in law, if we can amend law that would make it work, I think you got a lot of support because that program is very badly needed.
For instance, you have this one provider that can provide medical drug-assisted treatment who is a government employee. How do you split his time between government and non-government? That's got to be resolved.
Okay, I think that's something that could be resolved, right? So, but I'll leave it to you. If you're exploring it now, I'm just asking if you can, expedite those discussions and provide that to this committee.
Sure, we would explore that. And the reason why I'm confident that at this point in time, I think it would be cost-effective to provide that, because the way the 3.7 would be set up is we don't have to hire a full-time addiction specialist, because the time that he's going to spend in the 3.7 is probably between a quarter or a one-third of the time. So that two-thirds of his time is working on forensic psychiatry. So, but surely we will take your recommendation. The same thing with nurses. We don't have to hire a full-time, but we can hire a part-time because we have the resources. So what my plan actually is to co-share that with my adult inpatient for the nursing care.
Okay, so whatever it is, if you can please, because that's something that we've been talking about for a long time. What about you have the card for accreditation now, right? So, but you're still not billing. Is that correct?
No. Yes, we are billing.
Oh, you're billing. Okay. So what are you receiving from the billing? I know it's small. Right?
It's a measly 13,000 to date.
So what services are you billing for? What services are you billing for now?
We're billing for the medication.
Just for medication?
Yes.
So what about, I know there was one time that we passed the fee schedule for children's mental health, right? Is that something that...
Yes, we are currently working with Medicaid to get that moving. So right now we are collecting the data and looking at matching the encounter form, the data, with the progress notes to make sure it's consistent, and Medicaid will then approve for the payment.
Okay.
So we're sorry that it's slow, but
it's moving,
just about there. Yeah.
Okay, thank you. So for private, because I know private insurance too, that was part of your equation, your formula on what you may be receiving. And I believe I asked this before. What services that you provide, the department provides, that perhaps are not covered by insurance, by private insurance? Have you put that together yet?
Yes, we've been working with the commercial insurance. They have their own credentialing process, as long as it meets the requirement that its service is provided by a licensed professionals. Mm-hmm. Yeah, they will reimburse it.
Okay, so my question was, what types of services that you provide that perhaps are not mandated for insurances to cover. You know, like in the past, we've mandated that blood products be covered because it wasn't covered. So insurance companies now have to cover blood products. Are there any services you have, perhaps in the substance abuse programs that perhaps, you know, there's that ability for privately insured individuals to take on your services, but they're not being covered by insurance?
I believe because we have not adjudicated the drug and alcohol treatment, we will look into that. The
Okay.
one that was fee schedules that were adjudicated are purely for psychological services, licensed counselors, and psychiatric services.
Okay.
I don't believe that we have looked into the drug and alcohol treatment and services.
Okay, if I'm not mistaken, when the speaker had passed the fee schedule, I believe the anticipated revenue was a few million. It wasn't too big. Was it about 3 to 5 million?
What I heard is was 10 million.
Okay, no, but that was the high. But you know, realistically, I believe, if I'm not mistaken, it was about 3 to 5 million that you would anticipate. And in times like this, where we're looking for ways to fully fund you, that's really an option that I think, you know, the department should really pursue.
Right.
Okay, so my last question is, okay, we got the MRSS, so it's not funded. So
The staffing is not funded. The structures, the equipment was provided through a federal grant. The Rays of Hope building, we're trying to rehabilitate that using the DOI money. And I think Annie has the game plan wherein they're going to be using as a start off UOG interns. If you want to elaborate.
you can just turn on your mic, please.
Actually, Your Honor, we need the funding for the personnel to run. We are using university students, but you know, that's not a very reliable source. So we actually need employees to run the program. Yeah.
So what's your budget for?
For that, I don't have that information with me right now, but we're not looking at high-paying individuals to answer the phones. These are community program aid that will be answering the phones. And then we will need a psychiatric social worker, counselor position that would be providing the supervision. And it'll be working together with our current staffing that we have, both from adult services and children's services.
So can you provide that to us, because we'll work with the committee as well, because I've sat in some of the presentations, and this is a very effective program. Again, that's another program that is not funded but should be funded. So if you can provide what that budget is for this, then that's something that I know the committee will work with them to consider, including this as well.
Since the implementation for this MRSS comes in 2 phases, we'll probably give you the first phase, which is not a mobile response implementation, but just making sure that somebody who is qualified and credentialed should be answering those helpline. Because for now, Guam does not meet evidence-based standards for crisis helpline. So for the first phase, it would probably be very minimal. When we go to the second phase of activating a mobile response team on site, this is where the psychosocial workers, the counselors, and program aides would come in.
Okay, so you'll turn that into us within a few days?
I believe we did prepare a budget. We just didn't submit it, but we have that ready. We can just kind of fix it up a little bit and submit that if
Okay.
you need that one.
Thank you. And Ray, just the last question I have is the hazard pay, right? What I remember a few budgets ago, you've always said that the department has said that the lapses you have would be enough to cover once the guidelines were in place. I believe you were working with DOA. They took, I think GFT took you to court. You guys were, I guess, mandated to come up with something. right? Is that correct?
Correct.
If
And
you can
we are
explain.
current with our hazardous pay right now.
You're what?
We are current with.
You're current. Okay, so what's your, what is the policy?
GFT took us to court because we did not implement, they think we did not implement the hazardous pay guideline. But the court agreed with us that it is incumbent upon the individual who believes he was exposed to an unsafe environment and requires a documentation. They're not doing it. What they want is that from the time they go to work at 7:30, work 8 hours, what they want is automatically get a hazardous pay, which I strongly disagree because not all of our clients are combative, hostile, and a danger to self or gravely ill. There's got to be an extenuating circumstances that would allow the implementation of the hazardous pay. They are not providing that services. They are not providing those documentation. If they provide those documentation, I would certify that and send it to Department of Administration for execution.
Okay.
But
so,
it's on the board.
Okay, if you can just provide, because I haven't seen, we know, and you know that that's been an ongoing concern, right, from your employees. Yep. If you can provide us a copy of the policy, and of course, and you said there was a judgment in court.
Yeah, the lawsuit that they filed was actually settled.
Okay.
Because they were not following the guideline and the implementation requirement for the hazardous pay, okay, which means they have to submit an incident report that they were exposed to an unsafe, hostile environment.
Okay. If you can provide it to us so that's easier for us also to explain that.
We also kind of met with GFT and explained that to them as well. That, you know, when you look at the services that we are providing, it is to assist, to help these consumers. By asking for hazardous pay, carte blanche, that does a disservice to what we're working on in terms of stigma. Because not everybody with a mental illness is dangerous. And so we kind of explained to GFT that we needed them to be aware of that we can't just give hazardous pay because the employee is coming to work and is with the consumer. There's got to be some sort of a standard that we can differentiate when hazardous pay is needed or required. But as far as I'm aware of, we are current with whatever was turned in. We have submitted that, and I think hazardous pay is paid out to the employee.
Thank you, Mr. Vega. You know, you spoke a little bit about the New Beginnings program, the ODE program, that hasn't been in place for 10 years. But I was wondering, though, I recall in years past, there was a program for clients who have severe issues that are not manageable on Guam and are being sponsored off island for care. Is that still a scenario that exists, where we have residents who are cared for in off-island facilities?
We have, the last 2 years, sent 2 clients, but they were more of serious mental illness rather than a substance use disorder.
Okay, and are those clients still, are they still being maintained and treated off-island?
Yes, ma'am. And that's the reason why we are going to build this therapeutic group home so that we could bring them back in a fully assisted living facility.
Okay, so there are people presently off-island, because I was trying to put a number to what that associated cost is. I see what you're doing on Guam, but I had that in the back of my mind as something that is presently in place. So do you have an amount that is being spent on treating a set number of clients?
Yes, they're using the residential treatment fund, and the average monthly for almost all of them averages about 20,000 per month.
Per month. And how many people are we talking about?
We have six.
6 clients at 20,000 a month. And this has been going on for how
Well,
many years now?
The last two that we sent, they should be there about 2.5 years now. There was one that we sent sometime in 2012, so that would make them 6 years. But the long-term chronic clients we have in one in Texas facility, cumulative of more than 40 years.
For more than 40 years.
Right, cumulatively, the total number of, they practically have lived in the States since they were kids. And those are, if I may, those are the clients that we had a face-to-face evaluation with the clinical team, that we have made a determination that it is not in their best interest to come back. Otherwise, the chances of them regressing would be great. They're all traumatic brain injury clients that we don't have the capacity to provide the service here.
Are there families still maintaining residency in Guam?
Yes, ma'am. It's two are, I don't know if we could, since this is a public hearing, but two are U.S. citizen and two are not U.S. citizens.
I think what I'm getting at is I'm just trying to understand, because I vaguely recalled that, and I'm seeing what you're trying to do locally, and I'm trying to just balance the value of the investment in clients, where if you were to apply it locally, how far that would go and how many people it would impact versus the situation that you have with those that you have had to refer off island, for example, and what the impact of that, the cost of that for a few people versus the cost locally for more people. And that's what I'm trying to put have an understanding about where we're putting our money and why, particularly in long-term situations. It almost you would almost wonder if are they truly still residents of Guam or not, and at what point are they? At what point would these people be deemed to still be under our ward as opposed to?
You're exactly correct, Senator. There is a great benefit for us to open the fully assisted living facility, because the house that we have in mind right now has 6 rooms. So we should be able to accommodate those that are locally, that doesn't need to go off island, and at the same time bring back the 2 that are in off island. So yes, there's a cost benefit to us moving forward with a therapeutic group home. We will serve more, not just 2, but we could serve 4 or 6 more.
But this price of $20,000 a month is the average price for all of the off-island clients that you have. Is that correct, or is it more?
That's the average for the accommodation.
In total, or per client?
Each one of them is costing the government $20,000 per month.
So you're looking at 20,000 times 6 people, and that's really what
That is correct.
That's very different from 20,000 a month.
20,000 a month for all 6?
No.
For a total cost of almost $2 million, over $2 million to have those 6 away.
We're costing, the government is paying about $20,000 per client per month, and there's 6 of them. That's just the basic accommodation in that long-term facility. The other medical needs, the medications, are another associated cost. You're right, Mr. Speaker, that it could balloon to about 1.8 to 2 million.
For that service?
Yes,
okay.
yes.
That because 20 times 12 months is really nominal, as opposed to, you know, $250,000 versus $2 million is a big difference, and that's why I was trying to clarify what you were saying. So, all right. So I can see your focus then on your on-island investment. That makes absolute sense.
But I think to help the senator, how many years ago did the FMT tell you to open up a home locally? Wasn't that the basis of the FMT being brought in? On the first page on your director's office, you have 100 FMT positions. Can you explain to the senators what FMT stands for?
Federal Management Team. That's the receivership team that was court-ordered when the Department of Mental Health and Substance Abuses were not in compliance on 2 federal statutes that I know of.
And the suit was brought on behalf of the 6, well, at that point, there were about 4 of them that were off-island at the time. Is that correct?
From my understanding, there were 4.
Yes.
I believe there's only 3 living right now.
Yes. And when did we have the FMT? What years was Department of Public Health and Mental Health and Social Services, Behavioral Health and Wellness under an FMT? What years were you under receivership?
2010 to 2012. But prior to that, they were under court monitor. I think since 2003 or 5. Yes.
But the FMT in 2010 and 11 and 12 ordered Behavioral Health and Wellness and its predecessor, Department of Mental Health and Substance Abuse, to establish homes locally to bring these individuals back so that they could be within their own community. Is that correct?
That is correct.
And it was your clinical staff that met with some of them and determined that it would not be in the best interest of a couple of them not to bring them back because you had no services here for them. Or
that is correct.
Could not provide for them
That
here.
is correct.
And it was your department that has been under court order since 2012 to establish these homes to bring these individuals back. What is the progress of establishing the homes to bring these people? And how many have you brought back from the original order?
Can you repeat that?
How many individuals who were in the original lawsuit have you brought back to Guam as a result of complying with the FMTs and the court's order?
None of them, Mr. Speaker, because from my understanding, the permanent injunction involved local residents, not those on off-island.
It was both, wasn't it?
From what I know, they were all local residents, not the 4 individuals.
Yes, it was. No, it included them.
It was just the local residents, sir. At the time, 2 of them were in the inpatient unit, and we were not able to place them out in the community. So that's how the lawsuit started. And then another 2 were added onto the lawsuit.
So, except for providing for them off-island, why would you have to care about them in a court order? Aren't you in court just about every other month because you're not making your payments timely to to the residential care facilities in the States?
You know, not anymore. We've been on top of the payment for those. I have never been back to court in the last 8 months, I think, because we did not pay for the off-island clients.
Because I'm still getting notice that there's still problems with the residential care payments off-island. I thought there was an order to show cause within the last 3 months, if memory serves me right.
I don't know about the off-island. Maybe the use of the residential treatment.
So you have a Rays of Hope. You have a building
Yes.
that you guys bought. How many people are in it?
It's empty right now.
And that was designed to do what?
The Rays of Hope building is currently vacant, and the plan is to develop a drop-in center for young people on island, plus the MRSS is going to be housed there.
And how long has your department and its predecessor owned that building?
I believe since 2004 from Gura.
And how long has it not been used or vacant?
Just May was when Laddie Treatment Center moved out, and they are now in Chalampago. So May of 2017, and it's going to be renovated, the Rays of Hope, by the DOI funding so that it can be used for drop-in center for young people as well as for the mobile response.
And so the budget that you've provided us, if one of the attorneys is listening, God forbid Mr. Summerfleck is watching, we'd be in court tomorrow and under receivership again.
I absolutely agree with you, Mr. Speaker. That's why I'm begging you if we can.
No, I understand. And did you make that clear to the administration and to BBMR? We hollered and screamed that we did not want receivership when we were under receivership. We didn't want the FMT telling us to create 100 positions in the director's office. But what we're doing is transmitting a budget to the legislature that is 2/3 of what the department needs, or actually less than about 2/3 of what you guys need. And it will result in us being under receivership. Is that a yes? So we're doing both.
That's a possibility.
So all of OCA will soon be under receivership. Behavioral health and wellness will return to receiver again. And with the way that we're handling your neighbor across the street, we'll be under receiver of that one. Because of the way that the budget is being transmitted. It flabbergasted me. And this morning, I had the other agency that just came off receivership after 25 years of being under court-ordered receivership. This morning came in with a budget that was short by half. That was before it came here. And it's just servicing today.
Mr. Speaker, I think I've done my part. I'm begging this legislature.
No, I understand, Ray, and I appreciate
help me,
that.
get out.
I know, and I'm just saying, we've got to also have people understand that if we don't provide for this department, you will go into receivership, and we will have what we had 10 years ago.
Understood, Mr. Speaker.
And rather than have a confirmed director and deputy running the department, we had 2 FMTs being paid between the 2 of them almost $1 million to oversee the department. We'll recess this budget hearing until tomorrow morning at 10 o'clock to hear Guam Memorial Hospital.